Welcome to our Department of Psychiatry Grand Rounds. I'll have the pleasure of introducing the introducer, which I'll do in a minute. Just want to remind people that after the Grand Rounds, there's a question and answer session here, and we're going to wrap it up around 9:30, and then there'll be a session for trainees meeting with our Grand Round speaker across the hall in the seminar room there. So there are seats available for that. So if you're a trainee or a junior faculty person and want to continue the conversation and the questions and discuss more career-related issues, that's a great opportunity to do it in a sort of in a more intimate setting than the Grand Rounds. This morning, I have the pleasure of introducing Austin Grinberg, who's going to be introducing our Grand Round speaker. So I'll pass it on to him.
Good morning, everybody. I've been given 60 seconds. I timed it at 90 seconds, so I apologize in advance. So Dr. Chochinov is a distinguished professor of psychiatry. Well, let me back up for a second. So I am Austin Grinberg. I work at the VA on the integrated CL service with Dr. Bezai as one of the attendings, and it's a pleasure to introduce Dr. Chochinov because he's such a pillar in the field for collaborating with other disciplines. So Dr. Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at the Research Institute of Oncology and Hematology Cancer Center, Manitoba. His seminal publications addressing psychosocial dimensions of palliation have helped define core competencies and standards of end-of-life care. Dr. Chochinov has been a guest lecturer in most major academic institutions around the world. He's a recipient of the Order of Manitoba and an officer in the Order of Canada for his work in palliative care. He's the founder of the Canadian Virtual Hospice, a fellow of the Royal Society of Canada, and a fellow of the Canadian Academy of Health Sciences. In 2012, he received the FNG Star Award, which is the highest honor the Canadian Medical Association can bestow on one of its members. In 2015-16, he led the external panel for the Government of Canada, examining options for a legislative response to a Supreme Court decision regarding physician-hastened death. In addition to over 200 peer-reviewed publications, he is the co-editor of the Handbook of Psychiatry and Palliative Medicine, published by Oxford University, and the Journal of Palliative and Supportive Care. His most recent book, Dignity Therapy, Final Words for Final Days, is published by Oxford University Press and was the 2012 winner of the American Publishers Association Prose Award for Clinical Medicine. So I also wanted to highlight Dr. Chochinov's dedication to interdisciplinary collaboration and training. Some of us in this room had the opportunity to have a great discussion with Dr. Chochinov yesterday afternoon to hear about the importance of collaborating with other disciplines to build comprehensive bottom-up interventions that have high utility on the front lines of clinical practice. Dr. Chochinov has mentored students across healthcare disciplines and can serve as a model for how to build a clinically and academically strong collaborative environment. It's been an honor hearing some of Dr. Chochinov's work, and I look forward to learning more about his research program today. And without further ado, Dr. Harvey Chochinov.
Well, thank you, Austin. I appreciate that lovely introduction, and it really is an honor to be asked to come here to San Diego and to deliver Grand Rounds. The topic is going to be, as you see, on dignity, personhood, palliative end-of-life care. I know this department has a reputation of doing a very high-tech, biologically oriented psychiatry research. This is not only low-tech, this is no-tech research that I'm going to be presenting to you, but research nevertheless that hopefully you find of interest and sheds light on your understanding about psychiatric dimensions of end-of-life care and providing palliations to patients and their families. Now, this isn't actually the first time that I've had an opportunity to speak in San Diego. And in fact, the first time I was asked to speak here was at the San Diego Hospice. In the audience, we have Dr. Lori Montross, who has a faculty appointment here at UCSD. And at the time, Dr. Montross was a psychologist working at the San Diego Hospice, and she had been hired there by Charles Van Guten, who's a wonderful palliative care academic, well-known internationally. And Dr. Montross had been hired by Charles to deliver dignity therapy, which is a psychological intervention that was developed by our group. So Lori contacted me, and we began to talk about the possibility of my coming to the San Diego Hospice. So now you need to know that in negotiating the terms of our agreement, that my daughter Lauren is a comic book, graphic novel, pop culture maven. And for her, the equivalent of Nirvana was San Diego Comic-Con. And so we had this discussion, and the agreement was that, yes, I was interested in coming to San Diego Hospice. It had to coincide with Comic-Con. And she had to land me tickets, which I understood was nearly impossible to retrieve. But as it turned out, Lori knew somebody who knew somebody who knew somebody. And eventually the tickets were landed, and I was able to come to San Diego and to give a talk. Now, I can't say how memorable my talk was for the people who were in attendance, but I can say that for one young lady who is now a university professor of English, my first visit here was a peak life experience. Now, this is a skyline view of Winnipeg, and this is the Canadian Museum of Human Rights. And I point this out because I want to point out another connection between San Diego and Winnipeg, and that is that Dr. Murray Steen, who's on faculty here, is a former Winnipegger, was a classmate in medical school. So there are a number of connections between San Diego and myself, including Dr. Montross and of course, Murray Steen. Now, I came into the field of psycho-oncology and palliative care because of some very strong mentors and role models. And the first one that I'd like to mention is that of Jimmy Holland. Jimmy died last year at the age of 89. And she's recognized internationally as being the founder of the field of psycho-oncology. In the mid-1970s, Dr. Holland actually established a division of psychiatry at Memorial Sloan Kettering Cancer Center. She became the first woman to head a clinical department there, and she's credited with creating the first full-time psychiatry service in a major cancer hospital. She was the chief of psychiatry up until 1996, and she was the chairwoman of the Department of Psychiatry until 2003. And upon her death, in the New York Times obituary that I was just looking at last night and thinking about today's talk, William Breitbart, who some of you are familiar with and is currently the chief of psychiatry and chair, described her as a once-in-a-generation influencer. And I had the privilege of doing a fellowship with Jimmy following the conclusion of my psychiatry residency. Now, excuse me. Need some technical support here. The screen seems to have frozen. Oh, there we go. Okay. As a psychiatrist, I don't claim any technical skills. So as long as the technical issues are cooperating with me, I'm going to be fine. So the next person that I'd like to mention, and unfortunately that's not showing up quite as clearly as I'd like, but this is a photograph of Dame Cicely Saunders, a biography that was written by David Clark. And she is known as the founder of the modern hospice movement. Dame Saunders was a remarkable individual, and she had initially trained as a social worker. She also trained as a nurse, and eventually trained to become a physician. And I think kind of that multitude of training experiences and her interest in end-of-life care brought her to the conclusion that in order to deliver quality, comprehensive end-of-life care, one needs to be attentive to a multitude of domains of personhood, and that includes the physical, the psychosocial, and the spiritual. Early on in my career, I had the opportunity of meeting Dame Saunders. I was invited to St. Christopher's Hospice to deliver a grand rounds. And it was really an extraordinary privilege. And over the course of my career, I had an opportunity of meeting with her on a number of occasions. But this was actually a photograph that was taken upon the occasion of my very first meeting with Dame Saunders. I was to deliver grand rounds at about 10 in the morning. And this photograph was taken just before I was about to go in and deliver those rounds. Now, you may be wondering why we're both looking so pleased and relaxed in this particular photograph. And I can tell you that the reason is this. As I said, it was about 10 o'clock in the morning, just before my rounds were to begin. And Dame Saunders asked me if I would care for a sherry. And when the question came from Dame Saunders, it seemed obvious to me that there was only one answer. And the answer was, well, of course. And so she reached back into her liquor cabinet, which was here. And these are our empty sherry glasses. And I have to say, I can't ever recall feeling more relaxed to give a keynote address ever. I suppose the next influence that I'll talk about is not so much an individual, but a piece of research that was published in the American Journal of Psychiatry back in 1986, the very year that I was at Sloan Kettering working with Jimmy and the likes of Bill Breitbart and Kathy Foley and other kind of major pioneers in the field of psycho-oncology and pain management. So this is a paper that came out in the American Journal that, ironically, also was done in Winnipeg, and it was a paper that broached a seemingly obvious topic, and that is it ever normal for patients who are approaching end of life to desire early death? This wasn't outright requests for euthanasia or assisted suicide, but do dying patients ever contemplate this idea of dying sooner than later? And so in this particular study that was published by James Brown, who was one of my teachers, Paul Hentelef, who's a pioneer of palliative care in Canada, Samia Barakat, who was my former department chair, they actually screened 44 patients in a palliative care facility at St. Boniface Hospital, which was contained one of the first palliative care units in an inpatient setting. They screened 44 patients and found 10 patients who they described as having a genuine desire for early death. And then concurrently concluded that in evaluating these patients, that all of them were suffering from syndromal depression. So like all good research studies, it seemed to us that this study raised a number of important issues. Certainly said that there seemed to be a connection between this notion of depression and a wish to die. But for those of us who are working clinically in the area, we wondered, is it as simple as that? Is a wish to die only a reflection of syndromal depression, or might there be other factors that can account for whether or not somebody wants to go on living in the face of a terminal illness? So it was really as a result of this study that our group decided that we were going to kind of launch a program of research in the area of palliative care, and this really was the launching point for that area of research. And so we decided that we would do a much larger study. So this was a study, again, published in the American Journal, over 200 patients. The description of the people who were in our study, I'll describe, because this essentially describes the kind of patients that we've recruited into our studies over the years. And that is, for the most part, these are patients who have a prognosis of less than 6 months. The vast majority have an end-stage malignancy. The average age is the late 60s, early 70s. And all of them are receiving either inpatient palliative care, or they're receiving palliative care as part of their community-based palliative care program. So these are two papers that came out of Winnipeg looking at the issue of desire for death in the terminally ill. And occasionally people have said, what is it about Winnipeg that people keep on studying the wish to die? And I say, come and visit us in January, and this is no exaggeration, the temperatures can dip to minus 40 degrees Fahrenheit. So what did we learn in this larger study on desire for death in the terminally ill? Well, a number of interesting things. First of all, we learned that a wish to die is not a typical, at least a fleeting wish that life be over sooner than later, is not a typical occurrence in this patient population. You can see that 55% reported no desire for death on any occasion, which means that the remainder, at least occasionally, had a wish for life to be over sooner than later, with a small minority, about 8.5%, having a moderate or a genuine, consistent desire for early death. When we differentiated those with this ardent desire to die versus those who did not express a wish to die, we found the following. Amongst those patients who expressed a desire for death, the presence of pain or of moderate severity or greater was of the magnitude of about 80%. Amongst the group who wished to die, there was a perception of less available family support. And we also found that depression was a major player in a logistic regression model. Depression was the single most ardent predictor of desire for death. And the prevalence of depression in that group was of the magnitude of about 60% compared to about 7% amongst those who'd never expressed a wish to die. A number of years later, together with a dear colleague, Keith Wilson, we did another study. And this predated legislation in Canada by about a decade around medical assistance in dying. But Keith was interested in asking more explicitly about the wished for or the availability and attitudes towards euthanasia and assisted suicide in a national Canadian survey that we conducted a number of years ago. And we found that support amongst this terminal population for the availability of assisted dying was something of the magnitude of about 60%. 6% of patients said that if it was available to them now, it's something that they would want. And interestingly, 10% said that at some time in their past, it's something that they might have selected, but in their current circumstances, they would no longer wish to have a hastened death. So in essence, these are people who at one time said they would want to have euthanasia, but now had essentially changed their minds. Although I'm not going to go into the details of the recruitment, I put this up for one reason only, and that is to point out just how difficult and challenging doing this kind of research is, because the population that you're studying is exceedingly sick. Things are always changing, and recruiting the cohort into studies of this kind can be exceedingly challenging. You'll notice that we reviewed and vetted about 7,500 consults and admissions to palliative care units that participated in this national survey. And because of a variety of circumstances that made people unavailable, eventually we were able to get to a cohort of just under 400 patients who took part in the survey. As I said, we were able to look at a number of things that differentiated those who would wish to avail themselves of assisted death versus those who didn't. And you can see that there are a variety of issues that range from social concerns, issues around isolation, loss of resilience, feelings of loss of control, a number of physical differentiators, although interestingly enough, pain was not a significant player, and that's something that I'll return to because it seems to be replicated in various other studies that have broached these issues. Psychological variables such as anxiety, depression, and of course, sort of generalized global suffering and desire for death. Now, after we had done these studies, these cross-sectional studies looking at the issue of the wish to die in cohorts of patients who were approaching deaths, it occurred to us that in some ways we needed a different metaphor, so to speak. In essence, we had been using what I think of as a kind of a photograph metaphor. In cross-section, at one point in time, how do these patients look vis-a-vis the wish to die, desire for death? And perhaps a much more suitable metaphor is really a video cam, which can follow people sequentially over time. Because those of us who work in this area know that if there's one thing we can count on, it's that things are going to change. That things are rapidly moving in terms of the patient's experience, in terms of the patient's disease progression. And so we published a study in which we looked at the construct of will to live, and we used something called the Edmonton Symptom Assessment Scale, which is a very frequently used instrument. Certainly in Canada, it's very common, I'm not sure the extent to which it's used. Yes, I see a number of nods. And to that visual analog scale, we added a will to live visual analog. Anything scoring high on the ESAS is indicative of distress. And so a high score on the will to live visual analog is indicative of a paucity of will to live. We published this a number of years ago in The Lancet. This is a case study of an 80-year-old woman with colorectal cancer. And you can see that initially when she entered into the palliative care program, her will to live was poor. It improved substantially upon entering into the palliative care unit. And then towards the end of her life became much more erratic or much more erratically reported. Once patients could no longer give competent data, we stopped collecting information on them. And so you can see that, first of all, something as nebulous, as ephemeral as will to live is something that we can try and quantify, can try and grasp and follow sequentially over time. But what's also interesting about looking at this kind of data is you can start to look at the relationships between things like will to live and other sources of distress. And in this instance, we superimposed the data we had on will to live with her subjective reporting of pain. And you can see that pain and will to live are doing this kind of very intimate tango with one another, in which as pain seems to improve, so does will to live. Or as will to live starts to change, the experience of pain also shifts favorably. Either which way, in many ways, this is kind of exemplary of my understanding, and I think how many of us understand palliative care, and that is that any intervention, whatever domain you happen to be working in, has a ripple effect across kind of the multiple domains of patient experience, so that good pain management has very critical spiritual outcomes in terms of something as fundamental as the wish to go on living versus not. Now, again, this all predated the eventual change in legislation that took place in Canada in June of 2016. As was mentioned in the introduction, a year before, I was asked by the federal government to head up a panel looking at the issue of euthanasia and assisted suicide, doing an environmental scan, looking at the literature, and visiting a number of places, including Oregon and the Benelux countries, trying to look at their experience of euthanasia and assisted suicide. So since the law passed in 2016, there have been just about 3,700 people who have died as a result of euthanasia, and euthanasia is almost exclusively the mechanism by which people are availing themselves of hastened death in Canada. And there's been about a 30% increase over the last 6 months in terms of its uptake. So the experience in the Benelux countries was important, certainly in terms of the work that our panel did. And also going back to our program of research, after we had published our studies, we began to review some of the literature that was coming out of Holland and out of Switzerland. And we came across a study that had been commissioned by the Dutch government to look at MDEL, or medical decisions to end life. This was published by Paul Vandermaas. And what they reported was, first of all, that about 2.3% of deaths in Holland were occurring as a result of euthanasia. Euthanasia being delivery of an agent by a clinician that will directly result in the death of that patient. And a much smaller number, 0.3%, as a result of physician-assisted suicide, where the patient would be prescribed a medication that they could take at a time of their choosing in order to end their life. Now, as researchers, I mean, this was of interest to us, but even more interesting was the question as to why. Why might patients be seeking out a hastened death? Now, methodologically, of course, there were challenges in trying to answer this question, because all of these patients are now deceased. So how do you find out why these patients might have selected this particular path? And so what van der Maas did is he went back to the death records, and he identified physicians who had indicated on the death record that their patient had died as a result of assisted death, and then asked them the question, why did your patient seek out this particular mode of ending their life? And this is where the issue of dignity, which is an area that our research group has spent a lot of time looking at, first appeared on our research radar, if you will. You can see that there are a variety of reasons, according to Dutch physicians, as to why their patients sought out and received a hastened death. As I mentioned that pain was not a key player, pain as part of a constellation of symptoms was reported in 49% of instances, but pain alone, only 5% of patients, or 5% of clinicians reported that that's the reason why they thought that their patients sought out a hastened dying. A variety of other reasons were given, some rather vague and nebulous: tiredness of life, certainly loss of dependence, and we know that issues around maintenance of autonomy, certainly when our committee went to Oregon, and when you read the literature, I mean, this is one of the profound reasons that patients often cite as to why they might seek out assisted dying, is that it has to do with control and the maintenance of autonomy and controlling the timing and circumstances of their death. Unworthy dying, however that was defined, and it wasn't clearly defined by van der Maas. And then this notion of lost dignity, which was the most highly cited reason amongst this group of Dutch physicians who were reported in this particular study. So again, as a research group, in our minds, this raised a variety of questions. What do we mean by dignity? How is that defined? Again, it's a rather nebulous term. And so we began to review the literature. And what we found is that dignity was cited in a variety of ways, in a variety of places, and was used to support whatever position people happen to have in terms of their outlook on end-of-life practices. So whether we're talking about terminal sedation or we're talking about euthanasia and assisted dying, people would oftentimes play the dignity card as the ultimate reason why they did or did not support that particular approach. So with respect to euthanasia, those who were in support would say that, of course, this is about dignity. This is about autonomy. This is my life after all. Who else should determine when I die and how I die and the circumstances of my death? And those on the opposite side of that philosophical fence would say that, the taking of human life, this is an assault on dignity. And so we decided that if dignity was worth dying for, dignity was worth studying, and there really weren't any empirical studies at this time in the literature on this construct of dignity. And so we began a series of studies that I'll tell you about. And the first of these, again, appeared in the Lancet. And this was really a very simplistic study in terms of its design and approach, because we simply asked people to rate their sense of dignity on an ordinal scale. We modeled it on the SADS interview. And you can see, again, as in the desire for death findings, that about half of the group said that dignity was not something that they ever experienced as being undermined in the circumstances of them approaching end of life. And again, this was a cohort of just over 200 patients, which means that in the remainder of this group, that lost sense of dignity, at least on occasion, was not an infrequent experience, with a small minority, about 7%, expressing a strong sense that dignity had been undermined or fractured. If anything, we were rather surprised that when you think about this population and when you think about the various challenges they face, that the numbers were as low as they were, and speculated that perhaps there are a variety of explanations. One patient said to us that dignity was something that was God-given. So as long as there's life, there is dignity. So in essence, saying dignity is made of Teflon. It really doesn't matter what we throw at it, it'll bounce back. Dignity is indestructible because it really is part of the fabric of my humanity. And perhaps a more secular explanation might be recalling that all of these patients are being looked after in a quality comprehensive palliative care program. So all of these patients are receiving exemplary end-of-life care, including attentiveness to their physical, to their psychosocial, and their spiritual needs. So perhaps in the face of less excellent care, dignity might be more vulnerable to being undermined. Again, like the Desire for Death study, we decided to look at what differentiates those patients who say their dignity is intact versus those who say dignity is undermined or fractured or broken, if you will. And again, the results are perhaps not terribly surprising, but interesting to look at and document in an empirical way. So in terms of psychological symptoms, people who said that their dignity was fractured were much more likely to express a desire for death, have a loss of will to live, and experience a variety of psychological symptoms. And in some ways, it kind of suggests that perhaps loss of dignity is part of a final common pathway. If you think about the experiences in Belgium and Holland, perhaps loss of dignity is part of the final common pathway in which you lose your sense of dignity, leading to a heightened desire for death, loss of will to live, ergo requests around hastened death or assisted dying. When we look at some of the physical differentiators, things like pain seem to differentiate those whose dignity was intact versus those whose dignity was not. Difficulty with bowel functioning, something that we called part of the intimate dependencies, which I'll talk about in a moment, and even things as fundamental as how one physically appears, which I'll get back to momentarily. As I mentioned, the physical intimacies of care were things that seemed to differentiate those patients who felt that their dignity was intact versus those who felt that dignity had been undermined. In talks about compassion and in thinking about the issue of compassion, oftentimes, I like to remind students that for those of us, who find ourselves on the ward, these are things that are happening behind closed curtains. These are things that we really pay very little attention to and become either the unseen and the ordinary because they're kind of out of sight, out of mind. But to think about compassion and being a compassionate care provider really requires taking a moment to contemplate the possibility that you or someone you love becomes dependent in these profound and intimate ways. When we then did some modeling of the data to try and find out if there's some hierarchy in terms of trying to predict sense of dignity, we found that this notion of appearance was the most ardent predictor of whether or not one's dignity was intact versus not. And that is, how one is perceived to be seen by others, which is a bit of a mouthful, but interesting to contemplate. This idea of how am I perceived, how am I experienced by others. And several years after the fact, I discovered this wonderful etching by M.C. Escher, a Dutch graphic artist. And this was a self-portrait. And I think what's lovely about this, certainly it's much more interesting than talking about a logistic regression model. And what you can see in this self-portrait is that the reflection that Escher is seeing in the eye of what I choose to think of as a healthcare provider is a reflection that really captures the entirety of who he is. We see a middle-aged man in his apartment surrounded by his belongings, his photographs, his books. And think about it, if what patients see reflected in the eye of the healthcare provider is simply a problem checklist or a differential diagnosis, that it's much more likely that patients are going to experience their dignity as being undermined, or somehow that personhood has been eclipsed by patienthood. And for me, this was somewhat of an epiphany because it really said that quality palliative care is not simply what we're doing with patients, what we're doing with families. It also has something to do with what happens between our ears, what happens vis-a-vis our attitude towards that patient. And so because this struck me in such a profound way, I wrote an article that was published in the JCO called Dignity in the Eye of the Beholder, and putting forward again this idea that we in healthcare bear witness to the experience of our patients. And what patients are looking for is a reflection of themselves that captures the entirety of who they are, not just as a patient, but as a whole person. Now, up until now, we had been using, the methodologies that we had been using were quantitative. And I was having a wonderful discussion with some colleagues yesterday that I was meeting with, saying that qualitative methods are also of critical importance in palliative care particularly, because we can't claim to have good measures for all experiences that people encounter towards the end of life. And the qualitative research approach has the ability to capture some of the richness and some of the nuances that perhaps some of the quantitative outcome measures don't necessarily capture. And so we did a qualitative study of dignity in the terminally ill, enrolled a cohort of dying patients, asking them about this notion of dignity. What does it mean? What does it consist of? What are the things that might undermine dignity? What are the things that might support dignity towards the end of life? And on the basis of the qualitative outcomes, we came up with what we called a model of dignity in the terminally ill. This was published in Social Sciences and Medicine, and then was also published in JAMA. And what you can see is that there are a variety of issues that can either support or undermine the dignity of patients who are nearing the end of life. The model is not hierarchical, so different things will affect different people in different ways. For some people, dignity is about maintaining good symptom management and making sure that their comfort is well attended to. These are the illness-related concerns. For some people, dignity is really about how people in their surround react towards them. Again, this idea of the reflection in the eye of the beholder. So do we respect privacy, counterbalanced by offering good social support? We also introduced this term care tenor, or the tone of care, which I think is an important construct, and certainly when I've spoken about this, medical audiences seem to kind of get it. They understand, and I was speaking to an oncology nurse and presenting this notion, and she said, "Oh, I call that the fragrance of care." You know, it's that something that patients experience when I walk in the room. It's not necessarily about what I'm doing or what I'm saying. It's just something about my essence that they can sense that lets them know whether or not I'm there for them or whether I'm distracted by other things. And then finally, the dignity-conserving repertoire really had to do with the complexity of psychological and spiritual issues that can either support or undermine a patient's sense of dignity. And many of these things have to do with this whole notion of personhood, including something that we refer to as generativity, borrowing from Erik Erikson. And this idea of, you know, what influence will my life have as a result of my having been here? And that was important in terms of some of the later research that we did. On the basis of this model, we developed an outcome measure called the Patient Dignity Inventory, and I've actually brought copies of them with me. So if anybody wants to take one before they leave, please feel free to come up to the podium and I will give them to you. But this is an instrument, unlike the ESAS, somewhat expanded, in which we cover a variety of dimensions of end-of-life experience, including physical, psychological, existential, spiritual. And some of these questions may not be things that we routinely ask patients who are nearing end of life, but yet have profound existential resonance. For example, no longer feeling like the person that I once was. I can tell you that this is a profound existential issue for many patients approaching end of life, and something that is relatively prevalent amongst this cohort of patients. In fact, we did a study in which we put the patient dignity inventory into the hands of clinicians, and were able to look at the prevalence of some of these features in cohorts of dying patients towards end of life. And you can see that although depression is reported, or depressed symptoms are reported somewhere in the magnitude of about 20%, nearly 40% of patients say that this notion of no longer feeling like the person they once were is in fact something that is expressed relatively frequently. We also put this into the hands of psychosocial clinicians in a national study and had them use it in a kind of naturalistic way in their practice, and found that in nearly 80% of instances, the patient dignity inventory helped them identify issues that were previously unknown to them. So it's an instrument that can really be helpful in terms of helping move people towards areas of inquiry that they might not otherwise have looked at. So we really took seriously this notion of how do we change the lens of the healthcare provider? How do we change the way in which we see patients so that patients can experience us in a way as really acknowledging the totality of who they are as individuals? And the way in which we propose this can be done is by virtue of practicing what I call dignity-conserving care. And this is a paper that was published in the BMJ a number of years ago called the ABCDs of dignity-conserving care. And this sort of came from the idea of the ABCs of critical care, maintaining an airway, breathing, circulation. Well, what about the ABCDs of the humanities of care, and what might they be comprised of? As I've already said, our attitude, as I've pointed out, has a lot to do with how patients experience their care towards the end of life. We did a study in which we looked at the extent to which people would affiliate these particular issues with their sense of dignity. And you can see that, thinking how life might end, about 40%, no longer feeling like the person I was, 75% of patients says that is something that I would affiliate with a lost sense of dignity. But the most highly endorsed issues, feeling a burden to others, no longer feeling that they serve any purpose, and no longer feeling worthy, therefore, of respect or understanding. And in fact, that then is something that we can either bestow or withhold. So you can see how our attitude has a profound influence on end-of-life care experience. B is for behavior. I mean, do we ask permission to do an examination? Do we sit at the bedside or not? Do we use the rationale of non-cure as a reason for not actually being with patients in an attentive way? Because of time, and I see that I put far more in this talk than I have time to. It's okay if I go a little bit over. I'm getting the thumbs up. Good. I'll slow down then. C is for compassion. And this is this idea of understanding the suffering of another and the wish and the ability to respond to that suffering. I think in order to understand the area of this notion of suffering, we need to understand the sufferer, and we need to understand the essence of who that individual is. Some of you may have known Stuart Farber. He was a wonderful palliative care physician at the University of Washington, and he published a wonderful piece in the Journal of Pain and Symptom Management towards the end of his life. And what Stuart wrote was the following: with rare exception, the clinicians who treated me have good hearts, care deeply, but possess little or no knowledge of my thread. My thread is the narrative I use to make sense of my life. It is longitudinal, nonlinear, emotional, filled with contradictions, and integrates my life experiences into a coherent whole. It is within the values and meaning of my story that treatment decisions are made. What contributes to meaning and quality is not about living longer, but living a life that is consistent with my thread. Without knowing my thread, it's impossible for a clinician to provide respectful care. So I think this really gives this profound and powerful message that if we're going to deliver compassionate care, we need to understand this notion of the essence, or the metaphor he uses, the thread of who that individual is. But what if that thread is woven into a fabric that is less familiar to us, that perhaps is tattered by disability or by poverty or disenfranchisement? This woman is Catherine Frazee. This was the external panel that I referred to that examined the issues of euthanasia and assisted suicide. And Catherine is a wonderful educator, an activist, a researcher, poet, writer who has spinal muscular atrophy. And here's what she wrote about anticipating this notion of end-of-life experience. Quote, having to wear diapers and drooling are highly stigmatized departures from what is expected of adult bodies. Those of us who deviate from these norms experience social shame and stigma that erodes resilience and increases vulnerability. The more deeply these stigmatized accounts are embedded in our discourse and social policy, the more deeply virulent social prejudice takes hold within our culture. And then she goes on to say, what assurance can we offer that the physician who treats these patients at end of life will not stand at their bedside with horror or revulsion in his heart? The D of dignity conserving care is for dialogue, the conversations that we have with patients towards the end of life. We did a study in which we try to look at easy ways of eliciting personhood for patients and their families who were in end-of-life circumstances, and devised what we coined the patient dignity question, which simply asks, what should I know about you as a person to help me take the best care of you that I can? You might say that seems a rather peculiar thing to try and study empirically, although I was delighted to hear from one of my colleagues yesterday that this question is being used here at the UCSD in one of the clinical services. So how did we go about studying this? Well, what we did is we asked our research nurses to go to the bedside of patients in our palliative care ward, asked them if they would like to participate in a study that inquired about this notion of personhood, used this question as a prompt for a brief conversation to find out what they would want known about them as a person by their healthcare providers broadly. We then went and we documented this very briefly in a paragraph or two. We would then come back to the bedside to read it to the patient to see whether or not it in fact was accurate and kind of validate that in essence this does capture their thread, so to speak. And then the litmus test, is this something that they would want placed on their chart? Because indeed, if this is about changing the lens of the healthcare provider, then you would expect that this notion of personhood, the idea of making this thread highly visible, is something that they would want made available to all of their healthcare providers. And again, I'm going to take you at your word. I'll go over for perhaps 10 minutes or so. This was an example of one of the responses to the patient dignity inventory, and this was given by a First Nations woman who had experienced the residential school, which is a shameful kind of chapter in Canadian history where First Nations children were taken out of their homes, essentially to eliminate all aspects of Aboriginal culture. And what she said was the following. Mrs. F says that because of the residential school, she always had a hard time trusting people. She in fact moved 82 times so as not to let anyone get too close to her. Well, this has gone better over time. She still struggles with being able to trust people. She wants to, but it's hard for her. She sometimes worries that she won't be told the whole truth or that people will see her as not being deserving the whole truth. She appreciates people being friendly towards her, but is frightened of authority figures. She told me that people in white coats are frightening. You can just kind of think about this idea of even before when we walk in the room, there's this subtext that we can be entirely unaware of in walking in with our white coat. Authority scares me, but I'm not as bad as I used to be. So we enrolled a number of patients, 66 patients, and if the patient wasn't able to answer the patient dignity question, we asked their family member to respond on their behalf. And by the way, what we found in an analysis of the data is that the response of healthcare providers to the patient dignity question was identical, whether or not the source of information came from the patient or from the family member. What you can see is that according to patients, the information that was recorded invariably was accurate. It's something that they wanted placed on their chart. Surprising to us, many of them said that they wanted copies. They thought it was important information for their healthcare provider to know. They thought it could affect the care that they received, and in essence, all of them said it was something they would recommend for other patients or families to do. We then looked at healthcare provider responses, and in fact, 90% of them said that there's something that they learned new about the patient as a result of their response to the patient dignity question. And in many instances, this helped heighten things like empathy and influence their attitude towards patients and their sense of connectedness with that individual. Maybe I'll take the last few minutes that I have available to say that our model of dignity and end-of-life care also informed the creation of a psychological or psychotherapeutic approach to patients nearing the end of life. And this is something that we coined dignity therapy. And again, that's my taking this back full circle to Laurie Montross and the work that she was doing at San Diego Hospice. So what is dignity therapy, and how did we come about with this notion? Well, it was very much based on the model of dignity near the end of life. We knew that this notion of generativity was important according to dying patients. And so we thought, this is whatever we're going to do in terms of this psychotherapeutic conversation that we have with patients, that these would be conversations that would be recorded and transcribed and given to the patient. So in essence, whatever derived as a result of dignity therapy would be transcendent even of that patient's death. What would be the content in terms of the conversations that would take place? Well, we knew that these would be about notions of personhood, continuity of self, things that they might take pride in, maintaining hope and the like. And that the care tenor or the tone of care would be one of affirmation, non-judgmental. So the first patient that enrolled in dignity therapy was a gentleman who in fact had gone on a hunger strike and was determined that life was just no longer cooperating. His body was no longer cooperating with him. He wasn't suffering from syndromal depression, although told me at the outset of the interview, if he was in a European country where he could press the button now, he would. I explained to him what dignity therapy was and inquired whether or not it was something that he would be interested in doing. And he actually seemed quite taken with the notion. And I said, well, I'll come back tomorrow. I'll bring a tape recorder. I'll lead you through a conversation. And then it'll be my responsibility to transcribe it, to edit it, and to return it to you so that you can give it to your family members. And before I left the room, I asked him, now, and if you could press that button now, would you? And he said, well, no, I would want to do this first. So it was sort of like palliative care penicillin. And indeed, I did return the following day, and he disclosed a wonderful story of his family, of his children, of the immigration to this country, the untimely death of one of his children, and particular advice for his wife and concerns about how she might live out the remainder of her days. What I can say is that over time there have been a variety of studies, many studies looking at dignity therapy. And one of the first studies that we did, and this isn't preliminary data, this was the final data that was published in the JCO, and this is a study that took place in Canada and in Australia. You can see that there were high rates of satisfaction, patients reporting that it was helpful, increasing their sense of dignity, sense of purpose, meaning, will to live in many instances. And the vast majority saying this is something they believe would be or had been of help to their family members. 6 to 9 months after the death of these patients, we went back to the family members to ask them about their sense of what dignity therapy was and the impact on their now deceased loved one. And again, you can see that the vast majority, in fact, said that this is something that they thought that their loved one found was helpful, gave them a heightened sense of purpose, helped prepare them for death. Always interesting to me, 65% of them said that this was something that was as important as anything else that was done on their behalf in terms of the delivery of end-of-life care. And as well, from their own perspective, there seemed to be some impact on their own bereavement in that it was something that helped them during their time of grief, continued to be a source of comfort to their family members, and something that they would recommend to other families in similar circumstances. maybe I'll just skip ahead so that there is time for questioning, and that is to say that there have been a number of systematic reviews and meta-analyses on dignity therapy. I can say that when base rates of distress and when your primary measures are looking at things like depression and anxiety, it's exceedingly difficult under randomized control conditions to show differences on primary outcomes. And indeed, there have been about 100 papers now on dignity therapy, about 30 that are reporting primary data analysis. The outcomes on primary measures like depression and anxiety when base rates of distress are low are inconsistent. There's an interesting study that came out of Portugal that had higher base rates of distress and reported in randomized controlled trials that indeed dignity therapy significantly outperformed usual palliative care in terms of primary outcomes like depression, anxiety, and demoralization. But on positive self-reports and satisfaction, there are findings that very consistently show that dignity therapy has impact on things like sense of dignity, perceived heightened sense of dignity, meaning, purpose, hope, will to live, and this notion of generativity. There are currently 3 trials that I'm aware of that are taking place on dignity therapy. One is at the University of Florida. Diane Wilkie is doing a study in which she's looking at dignity therapy and dignity therapy delivered by nurses and by chaplains. There's one that's also taking place in Switzerland in which they're looking at dignity therapy being done as a collaboration between patients and families. And indeed, Laurie Matras here at the University of San Diego is doing a study on dignity therapy and looking at positive psychological outcomes with secondary measures looking at things like hope, life satisfaction, gratitude, and resilience. So you can see that there have been a variety of trials that have taken place worldwide. Training has taken place in a variety of settings, including, as I recall, a wonderful and memorable training session that took place at the former San Diego Hospice. And with that, I'll say that I've come full circle in terms of my talk. Hopefully this has given you some insights as to the work that we've been doing in the area of dignity, and it's helped operationalize it for you to the extent where dignity is something you can think about in terms of bringing these ideas to the bedside of dying patients and their family members. And with that, I'll stop, and I'm open to questions. Thank you.
For that outstanding, very thoughtful, and illuminating talk. We have time now for questions from the audience, so I'll just kind of pass the mic around.
Yeah, and thank you for sharing that very valuable paradigm shift, I would say.
Thanks so much.
Francis Collins, the director of the National Institutes of Health, wrote a book called The Language of God. And he started out as a physicist, and he wanted to be part of the biological revolution, so he decided to go into medicine. And while he was at his at the University of North Carolina, he was so struck by the patients suffering these terminal illnesses, and it was devastating to him. But he, these patients, who are many of who are people of faith, would say, "Oh, I'm going to a better place," and he felt that they handled their illnesses better than he did, and so he felt like he had to kind of investigate, what was giving them this coping strategy. And so he talked to his local pastor, who recommended C.S. Lewis, who's the very intellectual Christian apologist.
Yep.
And so I'm wondering about the role of spiritual faith in this dignity therapy and in your experience of dealing with these patients.
Thanks so much. Wonderful question. And yes, it's been a long time since I've read the work, the wonderful work of C.S. Lewis and some of his observations on his own grief, and I think the loss of his wife and his responses to that. We didn't specifically look at spirituality vis-a-vis the outcome data on dignity therapy, but I've been looking at the literature on spirituality, and that there's a conference coming up in the next couple of weeks at MD Anderson that's being co-sponsored by the hospital and is well by a division of the Vatican that has become very interested in the area of end-of-life care and quality palliative care, and the extent to which spirituality is a key ingredient. I can say that there have been a number of studies that have been done in the area. Christine Pacholsky is somebody whose work you may want to look into. She's certainly one of kind of the leading researchers in the area of medicine, palliative care, and the interface between end-of-life experience and spirituality. But there were a series of studies that were done in the late 90s, again at Memorial Sloan Kettering. And they were looking at the relationship between spirituality and a variety of end-of-life experiences. Now, they used a measure called the facet, and there were 2 dimensions to this instrument, looking at kind of both the meaning and another dimension looking at issues of faith and religiosity. And the findings were consistent and really quite profound, and that is that patients who reported higher scores on these instruments of spiritual faith or meaning consistently reported lower degrees of depression, lower desire for death, less suicidality, less in the way of hopelessness. And so clearly there seems to be some relationship between one's spiritual attitudes and outlook and these variety of end-of-life experiences that patients encounter. So thank you for that, a profound question.
I was interested in this idea of the tenor of care and physician attitudes. And so it seems like in your one study, the approach was to really get them to see the personhood of the patient. What is the role of kind of societal or individual ageism and a caregiver's own attitudes towards aging and death and dying?
And you say caregivers, you're talking about professional caregivers?
Yeah, so the physicians, for example, that are coming into the room, their own attitudes about aging, death, and dying, because ageism, of course, is a huge source of, a huge type of bias within particularly our Western society. And so are there any interventions that could be more global, not having to do with a particular patient, but helping the physician to have a different attitude towards aging and dying?
That's an interesting question. Next question. No, I mean, look, they're important issues, and I think what we all have to acknowledge is that, part of being human is having biases, and I think that Catherine Frazee in that wonderful quote that I shared with you shows us that all of us carry these biases, and it's not that we're bad people. It's that we're socialized in a particular way to have certain attitudes and to look at individuals in certain ways, depending on the circumstances in which we're raised. This is somewhat related, but I think illustrative of the point that I want to make. And it's not specifically looking at the issue of ageism, but it's looking about attitudes towards disability. And I spent a part of my research career working very closely with disability organizations and people who were very interested in the interface between disability and end-of-life care. And one of the people that I affiliated with was a man named Jim Dirksen, who had post-polio syndrome, was using a wheelchair for most of his life. And I remember one day being in conversation with him and talking about his kind of life experience, and made the mistake of referring to him as being wheelchair bound. It was the first time that I saw Jim nearly jump out of his chair, because I said, "Hold on a minute. Yeah, I'm not wheelchair bound." And I said, "Look, why are you getting so upset? What's wrong with the term wheelchair bound?" And what he pointed out to me is the fact that he wasn't wheelchair bound, and language is important. It conveys attitudes that we have towards people. He says, "I'm not wheelchair bound. I'm wheelchair liberated." And in saying he was wheelchair liberated, you allowed him to travel the world. He was one of Canada's leading proponents on disability rights and made sure that those disability rights were entrenched in the Canadian Charter of Human Rights. And so the point is that I think, part of our training is to sensitize ourselves to the fact that we do carry these biases and attitudes and outlooks, and those are things that need to be brought to our attention as part of our training, as part of our way of learning about the practice of medicine. The other thing that I can say is that we, again, getting back to the issue of aging and dignity therapy per se, we did do a pilot study in which, rather than using dignity therapy amongst terminally ill patients, we enrolled a cohort of patients who, the frail elderly in personal care homes. Half of the cohort were patients who were cognitively intact, and the other who had some degree of cognitive compromise and did this as a co-construction with their family member. And in some instances where they couldn't participate to any extent, the family member did it by way of proxy. And we did interview the healthcare provider in terms of the way in which the intervention, being able to see personhood through the lens of dignity therapy, changed their own attitude and their own viewpoint vis-a-vis the patient, now having seen dignity therapy and the reflection of personhood within those documents. And consistently, what physicians and healthcare providers reported to us is that knowing the story, again, getting back to Stuart Barber's metaphor, knowing the thread really changed the way in which they viewed that elderly individual. So thank you for that question.
Arlen Kramer, I work here at UCSD. Just to add a little bit more to that, I'm glad you brought up the term, the thread or the storytelling, and how do we make these kinds of changes? And I do think it goes right back to the beginning of the socializing in all departments, whether it be medicine, nursing, et cetera. And if we look at just the way that the first introduction of how patients are introduced to our medical students, it's always a case study. It's a 69-year-old man who's wheelchair bound, and there's no story, there's data. Yep. And so yes, we have to be concise, and there is a learning process, but where is the place for the story in the education? Where is the personhood of the people we're taking care of? And how do we invest in helping the next generation who are coming up to understand that and how to apply that? I recently went to a new physician, and when he heard that I worked here in palliative care, he was like, he's in internal medicine, and he says, that was like the most wonderful experience I had was working in palliative care. And I went, what? He says, how long were you with us? And he said, 2 weeks. But he said, it's like, I really walked away completely changed in the way that I view my patients. So I think there's so much room for us to be able to integrate this at all levels of education right from the beginning. And yeah, changing the established minds is always difficult.
Absolutely, absolutely. And I mean, and I like to think that the medical curriculum is changing and evolving over time, and these notions of personhood and kind of patient-centered or person-centered care are increasingly being introduced very early on in the training. Palliative care is probably being ahead of the curve on this, and again, it goes back to Dane Saunders and this idea of acknowledgement of those multitude of dimensions of personhood. And certainly, I mean, many people often will, and I'm sure you've had this experience, well, you work in palliative care, I mean, isn't that, how do you tolerate that? How do you tolerate that? And you must be a saint to be working in that area. Well, I mean, really what you find out when you speak to people who work in palliative care is the reason that they're there is because the work is so meaningful. And that besides, whatever the physiology, the medical interventions, the symptom management that they become familiar with, that knowing story is a part of, and it's an integral part of the work that I do. I didn't have time, and I sort of skipped through some of the slides on the patient dignity question. One of the things that I didn't show you is that we did evaluate the impact that having access to these stories had on the recipients, the healthcare providers. And one of the things that we reported in that particular paper is that there was an affiliation between being open to receiving these stories from patients and job satisfaction. And we can't necessarily talk about cause and effect, but it could be the fact that people who are more satisfied with their jobs are more likely to be open to finding out about the story, or the opposite, that finding out about who this individual is actually feeds into the fact that your job becomes all that more satisfying, and the kinds of things that you're dealing with are all that much more rich.
Thank you so much for the wonderful talk. I was wondering if with the dignity therapy, did you circle back and see if the rates of euthanasia or physician-assisted suicide, changed? I mean, those who had opted for that, if they were offered dignity therapy and if that made any difference in their decision.
Great question. So first off, I have to say that, dignity therapy wasn't created as, or ever meant to be a foil to kind of, this is our way of, asserting ourselves against the movement around euthanasia and assisted suicide. That was never our intent. It was never our agenda. We were certainly inspired by the data that came out of the Benelux countries, and it happened to be in the context of euthanasia, which was interesting to us, but it was really understanding why people wanted to die, we felt would give us insights around how we could deliver better end-of-life care. So I just have to point out that it wasn't intended kind of a priori as a way of addressing the problem of euthanasia and assisted suicide. I can only say anecdotally, because this is something that's happening in Winnipeg, again, as in all of Canada, there is now federal legislation. It's called Bill C-14. And it's referred to as MAID, or medical assistance in dying. And our MAID service, unlike I think any other service that is in existence across Canada delivering euthanasia, actually does offer dignity therapy to any patient who makes a request. My understanding is that about 20% of patients are actually doing dignity therapy, but I don't know of any instance, and we haven't collected data on this, but I don't know of any instance where the dignity therapy has had a direct connection or correlation with whether or not the patient decided to move forward with assisted dying or not. So, so I don't have a definitive answer for you, other than to point out that something unique is happening in Winnipeg around the issue of medical aid in dying and the availability of dignity therapy for those patients and families. I think there are a couple of studies that need to be done. Certainly one is looking at what impact does it have on the course of individuals who have sought out or made a formal request for aid in dying. But the other piece that I think needs to be looked at is the issue of impact on families, and what influence does having this kind of information, especially in the context of an assisted death, what difference does that make for families? Yes, please.
A few moments ago, you mentioned palliative care may be leading the way for other areas of treatment. And I wonder if, for those of us who are not working with patients at the end of their lives, whether the ABCDs of care that you described would help them. For example, patients with treatment refractory schizophrenia, many of whom have histories of substance use disorders, they may be missing teeth. They're not always treated with dignity and respect. And I just wonder if you know of any treatments for other serious mental illnesses, applications of this approach for those illnesses.
Yeah, no, I mean, excellent question. And although I wrote the BMJ article on the ABCs of dignity conserving care, it was written from my vantage point in the context of end-of-life care. But when you look at, that acronym, attitude, behavior, compassion, the conversations, the dialogue that we have with our patients, and even when you look at the patient dignity question, what do I need to know about you as a person in order to take the best care of you possible? To me, there's really nothing specific about those things that says this is about end of life. I think the only thing about end of life is it gives you kind of a vantage point in which you can look back on the totality of life and try and kind of glean wisdom from what you learn in terms of that positioning. But does this have applications across, the entirety of medicine? I mean, I would defy you to find an area of medicine that wouldn't be better informed, or a clinical encounter that wouldn't be better informed by finding out, well, what do I need to know about you as a human being in order to take better care of you? I've seen some case reports of dignity therapy actually in seriously mentally ill. I think there was a case report in depression. Not that I would recommend it exclusively as a treatment for depression. I mean, the data is not there. But does it have applications for individuals across medicine, or individuals for whatever reason they feel disenfranchised? And not too long ago, I received an email from a chaplain who is working with prison populations and working with elderly prisoners who were going to die incarcerated, and was doing dignity therapy with those individuals. So I thank you for pointing that out. This is not, certainly, I would hate to think that anybody not working in palliative care would leave this meeting saying, well, that really has nothing to do with me. I'm not working in palliative care, and personhood is really not something that I need to be attentive to. I would say quite the opposite. Hopefully, this resonates with anyone who is working in any clinical arena. So thank you for that.
Thank you very much for this very insightful.
And I didn't say anything about genomics, and I apologize, because
Oh,
I know
sorry.
but I warned you that I wasn't going to.
No, as a matter of fact, if we study genomics to see if how individually facing this issue of dignity, the personality dimension, my question to you is that as a psychiatrist, how do you differentiate difference from behavior therapy, psychotherapy, and dignity therapy? And how do we train a person to be familiar with the dignity therapy? And how long does it take to do the dignity therapy training? I think I'm very impressed with your concept of this dignity therapy, and more impressed, you have so much data to show us. It's not just a philosophical talking. You present, I'm very impressed. So would you let me know how to train myself? or of course, the difference is ultimately we are dealing with the end of the life patient mostly. But as already mentioned, this may apply to those patients with the low self-esteem and with the depression. So would you let me know how to, of course, you publish a book in dignity therapy, which we have to read and to understand more. So taking the opportunity you are here, just give us some brief sketch of the dignity therapy.
And the training. Just a few comments. First of all, it's interesting because you talk about the differentiation between dignity therapy and other forms of psychotherapy. One of the things that I can tell you is that some people who come to dignity therapy training, who are trained in other forms of psychotherapy, especially kind of looking at trying to help the patients glean insight, struggle with this very different agenda that dignity therapy sets for the patients in these sessions, because it's not necessarily about working through or gaining insight. It's really about facilitating the telling of story and the telling of story and insights and legacy that they would want to leave for a loved one. And I mean, just recently I was in Gainesville, Florida, doing some training with Diane Wilkie in that NIH study that I had mentioned. And there were a number of people at the training session who were really struggling with how do you shift the agenda? You know, how can you kind of take yourself out of your usual kind of psychotherapy paradigm and move yourself into this dignity therapy agenda? And I'm sure that Lori, and I think there are a few others in the audience who have some experience with dignity therapy, can also speak to that necessary shift. As far as the training goes, I mean, what we offer, and again, it's besides the book, which I mean, I think is the most, I mean, the papers that are studied, I mean, describe the methodology, but you know, I mean, in 3,000 words, you really can't talk about it in the kind of detail that's necessary. So the book is really the most comprehensive description of the techniques and the approach that needs to be taken. We offer a 3-day training course annually in Winnipeg, or have been. Each year it's a struggle with the logistics, and this year presents its own unique set of challenges and problems. Beyond that, I mean, what I can say is that having supervision and doing this therapy under the supervision of others who have experience is the best way of becoming, you know, good at it. And over time, indeed, what you find is that skills, like in any other area, improve, which has important outcomes, because when you think about being able to be a more organized interviewer, to be able to facilitate dignity therapy in a more streamlined way, that has implications in terms of the kind of material that you can retrieve from patients. It also has implications in terms of the coherence of the story that you get. And again, you have to recall that part of dignity therapy is what takes place in the here now. But part of dignity therapy is also about the creation of a legacy document, and the process of creating that legacy document is something that's going to be facilitated by somebody who is well trained in dignity therapy. So hopefully that gives you some brief insights as to, you know, how one goes about the process of training and the importance of experience and supervision in order to become kind of well versed.
I want to thank you on behalf of our department, our trainees, for this illuminating talk. I think many of us went into psychiatry and mental health fields because we're fascinated by the stories and life stories of our patients, and it's ironic that the way our training has evolved, that becomes less and less a part of what we do. And I really appreciate the fact that you've brought us back to this and in the context of dignity and end of life care. I don't know if it's dignified or not, but part of our tradition here, our story at UCSD, is to thank you on behalf of our department with a UC San Diego School of Medicine hat and the Department of Psychiatry from behind there. I don't know in the -40 weather if this is really functional, but at least you can keep it on the shelf as a sort of an optimistic symbol of what you have to look forward to.
In the plus, thank you. Does it look dignified?
Yes, absolutely.
It does. Okay, it does.
Thank you again. So there'll be a couple minutes break, and then the students